You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now, let's go beyond the abstract. Welcome back to another episode of Beyond the Abstract. Today we're talking with Dr. Mishka Terplan about his recent article in the Journal of Addiction Medicine titled Medications for Alcohol Use Disorder Among Birthing People with an Alcohol-Related Diagnosis. Dr. Terplan discusses interventions and messaging for AUD in pregnancy, MAUD initiation during pregnancy, and advice for providers caring for patients in this particular setting. Dr. Terplan is board certified in both obstetrics and gynecology and in addiction medicine. His primary clinical, research, public health, and advocacy interests lie along the intersections of reproductive and behavioral health. He's medical director at Friends Research Institute and adjunct faculty at the University of California, San Francisco, where he's a Substance Use Warmline clinician. He's also co-founder and co-director of Doing Right by Birth, a nonprofit that seeks to flip the script from drug exposure to early childhood development. Now let's get into today's talk with Dr. Mishka Terplan. First of all, again, thank you so much for taking the time to sit down and talk with us. Really excited to ask you some questions about these studies here. But first, I want to start at the beginning. I want to ask, why of all things addiction medicine? Can you share with me a little bit about how you became interested in this field and what have your experiences been like over the course of your career kind of up to this point?
Well, it's really wonderful to be here. Thank you so much for inviting me. And I guess the question, why addiction medicine, I'll be honest, over the last 25 years, the answer to that question has changed over time. How I answer it now, which I think is the most accurate way to answer it, is when I was a medical student in the 1990s, we didn't have any exposure to addiction medicine. It's not a field I thought existed. But I really liked working with people who use drugs. I worked in a syringe exchange. I volunteered in a syringe exchange as part of a small group of medical students who helped set up a volunteer clinic that ran concurrent with the syringe exchange, where we would, lance abscesses, give out antibiotics, wound care, stuff like that. We also had a clinic that I co-ran as a medical student that was only for women. And it was on Saturday mornings, and it was in the, kind of like the red light district of San Francisco, south of Market. And most of the clients were people who worked in the, local like strip clubs, and some were street-based sex workers. And it was the only clinic, the only time in all of medical school where the nurse practitioner students and the medical students intersected, which is, ironic in retrospect because we spend our careers in team-based work, yet our education is, highly segregated. And honestly, I really enjoyed working with people who use drugs. Then I discovered obstetrics and gynecology as a third-year medical student on, our standard rotations. It was not a field that I thought I would be interested in. I think my lack of anticipatory interest in it really reflected the generalized devaluation of women's health in general and, reproductive health in particular. In other words, it reflected, the patriarchy and misogyny in medicine. And really, to my surprise, I really enjoyed obstetrics and gynecology and found myself in this puzzling space of contemplating, going into a field I hadn't thought about at all. And so really then the arc of my career became trying to bring those two things together, my interest in working with people who use drugs with my clinical training in obstetrics and gynecology. And I'll just add to that, as I mentioned, I didn't really know what addiction medicine was as a medical student. As a resident, I started to learn a little bit about treatment. And it really wasn't until I was in practice and taking care of people that I even began to use a language of recovery. And that arc of really it beginning with ignorance. I think just from a solipsistic perspective, mirrors, the growth of the field, in some ways as well.
I want to ask a bit about your study now. I want to kind of transition to that. And one of the things I want to ask about is to reduce prenatal alcohol exposure. Both clinical and public health focus has been on educational messaging, screening, and brief behavioral interventions. How do you think that interventions and messaging differ for AUD when it comes to AUD and pregnancy?
Well, let me begin just by saying, amongst all of the substances, that people use in pregnancy, prescribed, not prescribed, amongst all of the substances that a fetus can be exposed to, alcohol is, the leading cause of preventable intellectual disability in the United States. So there's a large, legitimate public health perspective to address alcohol exposure in pregnancy. But I would say almost the totality of the messaging coming from CDC, NIAAA, NIDA, SAMHSA, ACOG, which is the American College of Obstetricians and Gynecologists, all of that messaging is really focused on use, in particular on not using, on abstinence. And we know that a certain percentage of people who use alcohol will meet criteria for an alcohol use disorder. They will be addicted to alcohol. And messaging around cessation in the context of substance use disorder is misaligned. Messaging around cessation in the context of alcohol use, where abrupt cessation can lead to withdrawal, which is a medical emergency, or can be a medical emergency, is not really the best messaging. And so I'm disappointed, I guess I'll say, in the HHS and professional society approaches to alcohol, which really neglect the fact that some people have a use disorder, just like any use disorder, that is, eminently treatable. And that would improve both birth outcomes and reduce, exposures, in utero exposures, and thereby, lessen the public health impact of alcohol-exposed pregnancies.
Well, let me ask you this too. You found that most medications for alcohol use disorder, they were prescribed for withdrawal symptoms and during the postpartum period rather than the year before giving birth. So this is kind of a two-part question. What are some of the potential risks and the benefits of clinicians prescribing one of the 3 FDA-approved medications for AUD during pregnancy? And how do you think that MAUD potentially help improve birth and fetal outcomes, especially considering the effects of heavy alcohol use during pregnancy?
Well, I'll answer the second question first, which is about the benefits of treatment in pregnancy, specifically around, medications. But note that of the 3 FDA-approved medications, disulfiram is probably not a good choice in pregnancy. But acamprosate and naltrexone, we have limited safety data. We have almost absent effectiveness data. But I think it's pretty clear that, whatever unknown might be attached to those 2 medications, that unknown is much less than the known harm of alcohol itself. But the question really of the benefit of medication or treatment in pregnancy is well known across, the literature. We have 50 plus years of literature on the treatment of alcohol use or of substance use disorder in pregnancy. And regardless of substance, we sort of see the same things, which is people with treated use disorder have better birth outcomes. And the population health burden of things we associate with substances generally, preterm birth, low birth weight, fetal demise, neonatal morbidity and mortality, those are predominantly, amongst the population of people with untreated disease. And people with treated disease look much more like folks without a use disorder in terms of those birth outcomes. So treatment works. And it reflects, the old adage, healthy mother equals healthy baby. We improve birth outcomes by managing chronic diseases in pregnancy. True of addiction, hypertension, seizure disorders, you name it. it's consistent with that messaging.
Springboarding off of that, though, I'm curious, what can be done then to encourage these health professionals kind of across specialties, because there's a lot that are going to interact with pregnant people. What can we do, or what can be done to encourage those professionals across specialties who are interacting with people who are pregnant with AUD to consider initiating some of these medications?
Yeah. Well, I think our data, which shows sort of a decrease in prescribing during pregnancy compared to the postpartum period for both withdrawal management and medications for alcohol use disorder. It reflects, a couple of things. One, that people are quote unquote afraid of treating a pregnant person. Two, when kind of pushed, people are more comfortable treating something that is perceived of and is acute, i.e. withdrawal, and less comfortable, prescribing for something that is chronic, i.e. AUD. And those reflect, biases that we actually see in other fields. We see this across, primary care. It's still in, 2025, it's not uncommon for a person who's stable on their antidepressant, when they get pregnant, their prescriber takes them off that medication. We see this with, other chronic disease medications. We see it more profoundly, I'll say, with medications for addiction treatment. But that sort of principle that there's something about pregnancy and in particular the fetus, that makes providers worried, and their reflex setting is to remove all medications. That again, I think reflects my reality as a medical student, 30 years ago, which was that this is a devalued space, which is not, people aren't getting, basic education in training, around it, because with very few exceptions, the risk of medication cessation is worse than the risk of medication initiation in pregnancy. Now, there's also a piece of this which just reflects the general kind of disregard of addiction across health professional practice. Compared to any other chronic disease, the proportion of people with an SUD receiving treatment is, far, far lower. And, roughly in the general population, 11% or so of people who meet criteria report receipt of any treatment in the past year, a number that is unchanged, really over the past 2 decades. We've had an increase in OUD treatment, but not a corresponding increase in SUD treatment across the population. And that's a massive failure of professional societies, of health agencies, and one that sorely needs to be addressed. What we see in pregnancy is those two things. It's the intersection of misogyny with the intersection of devaluation of use and use disorder as legitimate medical domains. And clearly pregnant people, their children, their families, suffer as a consequence of those blind spots. So what can we do? I think it's important in public health messaging from CDC, ACOG, and et cetera, to include alcohol use disorder in their education and their messaging. 2, we need to continue to, research around, safety and effectiveness of the existing, medications. And 3, we need to make these medications, more available, and really provide support, for health professionals who are considering, starting somebody on medication. And I'll say today, there's the UCSF Substance Use Warmline, which is a free service for any provider anywhere in the United States to get a consult. And there are many states that have specific perinatal, mental health or behavioral health warm lines, which include now in the last couple of years an SUD component. And so these are free services for providers anywhere. So if somebody is wondering whether this patient might be, somebody who I can start medications on in pregnancy, pre-pregnancy, or postpartum, they should call one of those lines, and they'll get expert consultation regarding, options and support.
Great resource. And I've got to ask, I mean, there's so much you've touched on already from this study and what you found, but I'm curious, what kind of future research questions kind of emerged from this study, and what kind of research studies do you think might be able to address those questions in the future?
Yeah, so in general, the top of the top of the evidence pyramid being the randomized controlled trial is something that is, not impossible to do, but trickier to do in pregnancy. Clearly, we can't assign people to exposures of alcohol or of illicit substances. We can assign them to, exposures, related to medications. And that's, one thing that one could think about doing would be some large RCT. RCTs are expensive. RCTs have internal versus external generalizability issues and stuff like that. But I do think that that's important. What has been happening up until now, and this article is a reflection of that, are really more secondary data analyses using existing data sets. The one we looked at was an insurance database, and querying those to look at, how many people are using medications, that you could get towards safety data on that. You could theoretically get towards effectiveness data on that. But the problem is, again, reflects this devalue, I think, of reproductive health, and that the coding around pregnancy is not always accurate. So there's a little bit of noise around that. Second, one could look at effectiveness, but in order to do that, we would need more than just a couple hundred people who receive the medication. Plus, we would need linkage to, data on, from behavioral health, and there remains, a non-integration of data sets and clinical service delivery systems between, prenatal care and primary care and hospital care and, the traditional behavioral health / addiction treatment system. And that will remain a problem. Both of those, how we code things, devalue and don't code stuff, as well as, the non-connection with important data sources for secondary data analyses, in the future. So I think we need to think about how we code stuff better in our existing data sets. I think we need to think about how to link to data that is of importance for the clinical questions we're asking, and thereby sort of tear down some of these silos and divisions, really, between fields and service deliveries.
Yeah. And you've touched on this. Now you were just kind of talking about some of the challenges, and you've mentioned it through the course of our talk today, but what kind of have you identified, or what do you see as some of those big challenges in terms of conducting this kind of research about the medications for pregnant and postpartum individuals? Like, what are some of the big things and obstacles that you see could be in the way that need to be addressed?
Well, this isn't just in pregnancy, but I would say, and this is going to be a statement that's more extremely phrased than what the reality actually is. But within addiction medicine, we tend to focus on illegal substances. And within prenatal care, we tend to focus on, exposures or use of illegal substances as well. And some of that reflects, I think, our own behaviors. Health professionals do use alcohol. I'll put it this way: they're far more likely to use alcohol than they are cocaine or heroin or fentanyl. They might have never used cocaine, heroin, or fentanyl and have used alcohol. It's something that's familiar to them. So asking, in our professional role, talking about something we do, it can become for some people awkward. And so they avoid it. Another reason is it's sort of the non-recognition of alcohol, I think, is the overuse of drug testing in particular urine drug testing, specifically within, prenatal care, as well as within, addiction treatment. And because the alcohol is not usually not captured on a urine drug test, and alcohol is it's not the best matrix really to look, at alcohol, and it clears the system rather rapidly. And so things that stick around longer are those things that we tend to see more in drug tests. So the absence of attention reflects, I think the primary technology that we use to identify, which is drug testing, which is an inappropriate, it's not the best tool to use. I'll put it that way. As well as reflects, this discomfort with, our own behaviors.
I've got to ask as we come to the close of our episode today. I mean, I think you're going to have some good answers on this one, Dr. Terplan, but what advice would you give? I mean, you've talked about so many things that you've sort of experienced and seen from your early career in med school to now, the things that you've studied. I'm curious, what advice would you give looking back to either your younger self, early on in your career, early on in your medical career or medical school? And then what advice would you maybe impart onto the new up and coming generation of addiction medicine professionals that are going to be getting involved in this field, or maybe just finding an interest in this field now?
Well, I'll begin by saying that it's really the up and coming generation of folks that give me hope. When me and a handful of other people first sat down like 15 more years ago to try to create a group of health professionals interested in the intersections of gender and behavioral health, there were literally 5 of us in a room. And today there's like a listserv that's grown out of that. That's like a couple thousand. Every few weeks, I get an email from a med student, or sometimes even an undergrad, and certainly like residents and fellows who are interested in these specific spaces. And that's really, I think that sort of generational arc is how I think about change, and gives me hope. But also, I have to acknowledge your question in this particular historical moment, whatever, couple of months into the current administration. And this is a really rough time. It's a rough time, for, what we're seeing, I guess I'll say, is that, medicine, science, public health really being under attack. We're seeing projects being terminated. We're seeing domains of inquiry, which are, I think, standard from a public health perspective, in particular, looking at equity, looking at subpopulations, looking at pregnancy, looking at, infectious diseases. We're seeing projects related to those things being terminated. We're seeing health systems being really like non-creative in their response. And just like when anything that is punitive in society impacts those that are, the more marginalized you are, the more impacted you are. And within science and medicine, the people who are more marginalized or marginal are those that are younger, those that are women, those that are people of color. And so this is a rough time to give advice. And I worry that what my advice is a little sort of Pollyannish, however you say that word. Because the thing that I reflect on is, one, that this work has always been devalued. It's always been underfunded. It's always been under-resourced. It's always been, under-workforced. The care of pregnant people and parenting people who use drugs is not something that has ever been, valued. And today it's going to be even more devalued than it was before. But somewhere that's a difference of grade rather than category. But what makes us strong is our community. And the thing that has brought me the most joy in my career has been the people that I have gotten to know along the way, not just other health professionals, but lawyers, activist lawyers, people working community-based organizations, people, the patients I've cared for, the people who, whose lives have been, profoundly impacted, negatively impacted by the child welfare system, but have, stood up an organization, to resist, that sort of literally like state violence. And so I think the important thing is to find your community, to articulate a horizon. What is the world we would like to inhabit? Can we share in those values? And then, work towards that. This is a rough time. And so it's a time to, articulate, to think, articulate, and to work together. And that means in close collaboration with, our allies in other fields, and in close collaboration, with community-based organizations.
Amazing advice. Dr. Terplan, thank you so much for taking the time to sit down and talk with me today. It's been a great conversation.
Well, thank you so much for having me. It's been a pleasure.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.